Dear students, I am Professor LAEEQ from Pediatric Department, and I will be talking about another important clinical issue in children. The topic for today's discussion is fever and rash in a child. To begin the discussion, let's find out what are the objectives in my study, in my talk. Well, I said that this is a very common problem that whenever you are handling children, you are liable to come across with children developing fever and rash, and they need your expert advice. So, your first aim would be that with this clinical problem, we should learn how to make a differential diagnosis of the cause of a possible rash with fever in a young child. Unfortunately, the general public only says that every child developing fever and rash is measles, which is totally wrong. So, we should know the differential clinical points favoring either disease. Second, when should we call someone as having measles? There are very important salient clinical features of this highly infectious disease called measles, but that need to be differentiated. Well, if we diagnose him that this is case of measles, then what is the standard case management of measles? People are treating this important entity very wrong footings, with antibiotics, with antivirals, with so many things which are not needed in this child, but they are being practiced all over. Well, we should know that measles in certain cases is complicated by a number of clinical problems, and we should be aware of them, we should diagnose them, and we should treat them accordingly. Well, measles is not a single one case in a family, but again, when we see it from the community health perspective, we find it's a very important disease. So, we should learn what are the preventive strategies in this very common public health issue. So, in the developing country, measles is very important regarding the community health. There are always news about an epidemic in a country, and sometimes the condition becomes global. So, we should know that this important disease should be prevented at all costs, especially in children. So, these are the objectives which we need to fulfill at the end of my lecture. Right. Let's start with a case history. I'm showing you a photograph of a 1-year-old infant who was in previously good health but then developed high-grade fever of 1 or 2 degrees Fahrenheit for 2 days with mild rhinorrhea, running nose, watering from the nose, mild cough, and then parents noted that he has a pink pinpoint macular rash on the face and upper chest. So, this child has received his vaccination. The rash was seen by the doctor in the follow-up, and then after a stay of around 3 days, it disappeared. But parents were very worried and very upset. They seek your advice. So, what are the clinical points in managing this patient? Number one, first, what is your clinical impression that what is the clinical disease in this patient? Second, what are other possibilities? Because I said that public always consider that every child with a fever with a rash is measles, which is absolutely wrong. So, as a doctor, you must know what are other possibilities which can have the same presentation. And third, what should we do? How should we manage this patient? So please write down on a piece of paper the answer to the three questions that I have already raised. You see the patient, and then you have the clinical questions. We'll take this question and their answer at the end of my lecture. Right. I am showing you certain clinical photographs, and you should know how to describe them. This child, who is a young boy, he has developed pink-colored, generalized macular rash on the face, on the trunk, which you can see a little bit raised. It is maculopapular, but it is diffuse, generalized. So in the rash, we should note down the extent of the rash, from where it started, when did it spread, in how many days, what is the nature of the rash, macular, papular, vesicular, pustular, and so many others. This patient again has got a rash, but what is most obvious? He has got watering from the eyes and watering from the nose. His eyes appear swollen and red. So he has got rhinorrhea and he has got conjunctivitis with watering from the eyes. This must be noted in all these cases. This is called what is known as viral catarrh. Then you see the extent of the rash, that is from the face, trunk, lower limbs, it is gradually descending fashion from cephalocaudal direction. So we should note down where the rash started and did it spread immediately, rapidly, or within 2-3 days. It started from the face and then gradually came down to the lower limbs, followed by total clearance, disappearance, or was it followed by some scaling and a fading rash? Rash is not always macular, especially in the malnourished children, especially in the black-colored races. You find rash which is not typical of measles, but still it has a different presentation. It gives a lot of pigmentation and scaling as the rash is now subsiding in this African child. We must examine patient's oral cavity because we know that there are Koplik spots. Now, these are very fine, small, grayish-white spots on the raised above the surface, and they are surrounded by macular erythema. So, these are pathognomonic Koplik spots typically seen on the buccal, gingival, and the labial mucosa. For that, you have to open the patient's mouth with the help of tongue depressor and torch and look what is inside. These are again Koplik spots. You open the mouth and then you find fine red-colored macular spots, which is called enanthem, on the soft palate on the inside of the cheeks. Well, now coming to the prototype of a child with a rash, we come to the measles with some of the basic facts that you should be aware of. Measles is highly contagious disease that is spreads very rapidly from person to person without any vector. is direct contact of the index case to his surrounding recipient host, most of them become infected very easily until they are having immunity. It is single type of virus, just one type. There are no multiple viral type, but just one type, RNA virus, and only humans are the host. It doesn't infect other races, doesn't infect other animal or vectors. And it has got an endemic in a particular community where few cases happen throughout the season, and sometime the disease becomes epidemic. That is, vast majority of children, if they are susceptible, they develop measles. So the disease can be endemic or epidemic both ways. Measles spreads through the respiratory tract mostly. Very few cases, even the eye secretions, when they are not properly handled, they can infect the next person. And from the respiratory tract, when the patient coughs, sneezes, or shouts, then these persons, they infect the surrounding persons through direct contact. The incubation period is from 8 to 12 days, and there are no symptoms, but the patient has been exposed to an open case of measles. So in due course of time, he will develop the disease unless he has got immunity. The children, once they are having incubation period, they become infectious to others. That is, 3 days before the appearance of rash and 4 days after the appearance of rash. So total this period is 7 days. Even when the patient do not have a rash, but they just have got a mild fever, cough, rhinorrhea, for 3 days they are spreading the disease to the nearby contacts. Remember that adults, mostly the children are the patient, but again, if some adult has not been exposed to virus, and if his first contact is in the adult stage, the disease sometimes becomes very serious. Now this emphasizes the importance of spread of measles virus through infectious particle present inside the patient's respiratory secretions. When a person coughs, sneezes, or talks very loudly, then there are water suspended particles, and then there are small microscopic droplet nuclei which circulate in the air and then can infect the surrounding persons. And for that, the mask and the cough etiquette are very important to its prevention. A little bit of pathology and pathogenesis, that the virus infects the skin through the bloodstream. There is viremia. From the viremia, the virus settles in the skin, produces exanthem, which is the presence of the skin lesions on the skin, and then the virus also infects and is visible in the mucous membranes called enanthem. And if you just examine the patient's lymph nodes and the lymphocyte, you will find typical viral-induced giant cells, which are sometimes, otherwise the blood picture is unremarkable, except a little bit of lymphocytosis and maybe low white cell count. Now, coming to the clinical feature of this very important disease, we have 4 phases. The first phase is incubation period. Just patient is having viremia, patient is having multiplication of virus inside his own body, but again no symptoms. This period may last from 8 to 12 days after the exposure has taken place, followed by prodromal phase. In the prodromal phase, any patient only has fever, rhinorrhea, watering from eyes, cough, sneezing, but again nothing is very specific. You cannot diagnose the child in this condition. It is non-specific viral catarrh with fever that is important for prodromal phase. This usually lasts for 3 to 4 days. Then followed by exanthematous phase, in which the child develops first appearance of red-colored fine dots, especially on the forehead, behind the ear, between the hairline, on the forehead, and then within a day it spreads to involve the face, upper trunk. On the second day involves the whole abdomen and the proximal extremity, and on the third day it reaches the distal part of hands and feet and extremity. So that is how the rash spreads from cephalocaudal direction. Then the recovery phase starts. The patient has got a very high grade fever, even up to 104 during exanthematous phase. Very sick looking with high grade fever, terribly sick looking child. In the recovery phase, the fever gradually subsides in 2 to 3 days time, and then the rash start clearing. First it unites, they make big patches of the skin, and then gradually start clearing from the head to the toes, leaving behind some pigmentation on the skin and scaling. So when the patient has not come to us in the initial stage, but come to us in the late stages, we still can diagnose him as having history of measles in the last 7 days by the appearance of pigmentation on the skin and scaling rash, which may last for few days. And that can also help to differentiate measles from other conditions. I said that fever is always high grade. 103, 104 is very commonly noted. And then there is always enanthem, that is a rash, that is lesions, vasculitic lesions on the mucous membrane seen inside the oral cavity. They have got cough, coryza, and conjunctivitis, labeled as 3 C's, which always accompany. They have got exanthem, which is just like a maculopapular rash, starting from the face and spreading from the head to toes. And then in the last stages, around 6-7 days, they develop a desquamation of the rash, scaling is there, and pigmentation is frequently noted. And some children, they also have generalized lymph node enlargement, which again settles over 1 to 2 weeks' time. This is the clinical course of measles in a young child. So, how do we diagnose it clinically? A child having fever and rash can have anything. But again, the presence of 3 C's, that is cough, coryza, and conjunctivitis, are almost pathognomonic. Cough is quite important event. Repeated coughs, hacking cough, irritating cough. Coryza is watering from the nose, watering from the eyes, and presence of the red eyes with discharge and watering. These 3 C's frequently happen together. Remember that measles have got a very important linkage with the malnutrition. In both ways, in either direction. Child having malnutrition frequently get measles because of a low immunity, and children who get measles frequently develop malnutrition as a result of the disease. So these two things go hand to hand. Again, this is a sick child who had a history of measles and then became malnourished. So malnutrition and measles are very closely interlinked. I have given you the reason why. Because the malnourished children have got low immunity, they develop complications very often, they have got a very long stay in the hospital, and many of them, they die very rapidly. And if you follow these children, even when they are saved, many of them, they develop reactivation of tuberculosis. So these children remain sick for a couple of months. First, because of measles, and then once measles is over, they have certain complications like reactivation of tuberculosis as a result of low immunity. These are the children who are frequently deprived of vaccination. The mother thinks that he is very malnourished, बहुत कमज़ोर बच्चा है, इसको हिफाजती टीके ना लगवाए जाएं। हालांकि इस बच्चे को सबसे ज़्यादा ज़रूरत है कि हम इनको वैक्सीनेशन लगाएं, बिकॉज अगर एक बच्चे को मीजल्स हो जाए और वो मेलनरिश्ड भी है तो उसकी मोर्टेलिटी बहुत ज़्यादा है, उसकी मॉर्बिडिटी बहुत ज़्यादा है। नाउ रिगार्डिंग आवर क्लिनिकल अप्रोच, हमने अभी कहा है कि अगर एक बच्चे में फीवर है, रैश है और उसको देखने में 3 C नज़र आ रहे हैं, लाइक कॉफ, कोराइजा एंड कंजक्टिवाइटिस, हम उसे कहते हैं ही इज ए मोस्ट लाइकली ए सस्पेक्टेड केस ऑफ मीजल्स। फिर आप पर डिपेंड करता है, आप उसके गौर से देखें, हिस्ट्री ऑफ कॉन्टैक्ट पूछें, और अगर इस वक्त माशरे में लोकल कम्युनिटी में एपिडेमिक फैला हुआ है या बीमारी के केसेस नज़र आ रहे हैं फैमिली में, सराउंडिंग में, तो ये बन जाता है प्रोबेबल मीजल, मोस्ट लाइकली, highly likely that this is measles. However, we confirmed level case of measles is said to occur when the patient has all features mentioned above. He has got complex spot which are pathognomonic of confirmed measles, and if you are fortunate, sometime you can go for the antibodies in the blood, you can go for the PCR, and go for immunofluorescence technique, but these are rarely done. Mostly it's a clinical signs and the presence of the complex spot and the history of contact in an epidemic situation that we can be sure that this child has measles. Right. WHO has taught us that all cases are not alike. Some are mild, some are moderate, some are severe measles. So how do we classify them? IMNCI program has taken this and divided all diseases के clinical case into 3 categories. One, simple measles, जो कि मैंने अभी आपको describe किया है, simple measles. Number 2, measles with eye and mouth complication, which mean patient has got mouth ulceration, patient has got eye complication like conjunctivitis, like keratitis, like purulent discharge, which are very important and important condition for the chances of good vision in the future as well. So the second category is once patient get measles with eye and mouth complication. Again, these require special care. And the most severe form of measles is that when we see that child has severe measles with complication, which mean patient has become drowsy, unarousable, he vomits whatever is given, he develops fits and cannot feed himself. So these are all the danger signs that we learned in IMNCA program. So once the danger signs are present in a case of measles, it becomes severe, complicated measles, which is important. The outcome of these 3 disease severe condition will be different. So what complication may ensue? Pneumonia. The X-ray typically shows presence of bilateral inflammatory pneumonic changes in both lung field. So pneumonia can be viral, pneumonia can be bacterial like pneumococcus, streptococcal, H. influenza, and staphylococcal. So these are all common cause of pneumonia. Some children, they develop croup. They develop upper airway inflammation because of the informed laryngeal mucosa. They develop tracheitis. They develop bronchiolitis. They develop acute otitis media, and frequently children come with discharging ears as a result of measles infection. And after 3 months, sometimes they come with the primary tuberculosis, who has become reactivated. So they have got pulmonary changes of tuberculosis because of the low immunity with spread of reactivation of primary tuberculosis. Again, diarrhea is again very common. These children get diarrhea because of the dysentery as a result of Shigella infection, and they develop persistent diarrhea. That is, diarrhea continues beyond 14 days. It doesn't recover. So they become more and more malnourished as a result of malabsorption. Some children are very unfortunate. They develop CNS complications, like they develop fits, which can be due to febrile fits, or measles virus causing encephalitis, and sometimes causing features of panencephalitis called SSPE. After maybe 5-10 years, patient develop progressive brain damage with features of encephalitis. Some children, they develop myocarditis, develop heart failure. Some children, they develop bone marrow suppression because a virus invades the bone marrow and suppresses the precursor cell, pancytopenia. And some children develop bleeding tendency all over. Some call it black measles because they have got a low platelet count and they develop features of DIC. So who gets these complications? Well, very young age, below 1 year or up to 5 years, they are at risk. If there is many children kept in a small community with overcrowding, then the cases become severe. With every successive case, it becomes severe day by day. If the child is malnourished, you get severe measles. Communities in which vitamin A has not been given, they have got a low vitamin A level in their blood, and the disease is always very severe. And those children who are already getting immunosuppressant therapy like steroids and other drugs, they get very severe measles because of the low immunity. How do we manage these children? Well, there are general measures like lower the body temperature by sponging, by exposure, give them paracetamol orally, and sometimes in emergency intravenously, increase fluid intake because of the more requirement and more losses. Give them a good aerated room to keep inside home. They do not need to be hospitalized. Most of them, they can be managed at home. Look for the eye problems. So regular saline washing for both eyes is very important. Sometimes we need some local antibiotics for the mouth ulcers as well. Vitamin A, which is basically, we thought that this vitamin is required for the visual acuity and the night vision. But no, in children, this vitamin is essential vitamin to maintain the integrity of the mucosa of young children. It has been said that vitamin A should be labeled as anti-infective vitamin because it helps to maintain the local immunity of the mucosa, both in the gut and both in the respiratory tract and the ear. So vitamin A therapy in large doses has become a central point in managing cases of measles. Vitamin A, if the child is less than 6 months of age, should be given in a dose of 50,000 units. We have got the capsules of vitamin A available, and they can be punctured and the dose can be instilled into the baby's mouth. Age between 6 to 12 months, you need to give 100,000 units. And children who are more than 12 months, they require 2 lakh units, 200,000 units. So this dose is to be given on the first day, then repeated second day, and then continue at the third dose at the 1 month period. Remember, cases of measles will not get any benefit by any antibiotic. So do not give antibiotic. No antiviral is effective against measles vaccine. No cough syrups are required. Just give them hot liquid to drink repeatedly to suppress the cough. How do you prevent them? Prevention is possible by active immunization. That is, we have got the measles vaccine available with us. You give the first dose of measles vaccine 0.5 ml subcutaneously at 9 months of age, and give a second dose of measles vaccine 0.5 ml subcutaneously at 12 to 15 months. Sometime this age limit can be decreased to 6 months in case of epidemics. It has been found that when these two doses are properly given to a child, then almost 85% of children, they develop adequate antiviral antibodies in their blood, so they have got seroconversion. Now they are protected, and they will not get second attack of measles. They will not get clinical measles now. And nowadays, the standard practice is to give them MMR, which contain measles, mumps, and rubella, if the patient can afford, because it's not available in EPI. Sometimes there is a case of measles in a small house, and parents want to vaccinate their children to protect them. So if exposure has occurred within less than 72 hours, you vaccinate these children who are susceptible. And again, if the patient has been exposed within the last 6 days, then immunoglobulins can be given to this recipient in a dose of 0.25 ml per kg intramuscularly. In that case, usually the disease is modified. Even if the patient is exposed, he will get a very mild disease and he will not develop a very severe attack of measles. Now, coming to the same question, that what thing come to your mind? I am showing you a patient having rubella. You see that the measles virus, that the rash or the German measles quite resembles measles in its clinical presentation, but with some differences. First, it usually infects the face and the upper trunk. Second, it's a 3-day rash. It doesn't last for 7 or 10 days. It immediately clears within 3 days, and as a diagnostic feature, frequently accompanied by presence and palpable lymph node in the occipital area, suboccipital area. So these are the features of German measles to differentiate from measles. Another important condition which children come to us is roseola infantum. There is again, baby get high-grade fever and a macular rash. The main difference between measles and roseola infantum is that once the patient gets rash on the second or third day, the fever immediately comes down to normal. On the other hand, if the patient has measles infection, when the rash appears, the fever also increases. So fever continues for initial 2 to 3, 4 days during an attack of measles. While roseola infantum, it frequently comes down to normal. Erythema infectiosum, another disease in which the maculopapular rash frequently involves the region of face and upper trunk. But again, it is mild disease and looks as if the patient has been slapped. But again, it clears within a couple of days. Meningococcemia. The rash is not maculopapular to begin with, but again, it frequently becomes hemorrhagic. These are, you find petechiae and ecchymosis and purpura, which is diagnostic of meningococcal rash. Allergic rash appears suddenly, abruptly, and couple of hours, the whole body has got itchy macular rash, and frequently it is raised above the level. It has got urticaria, So these differentiate from allergic rashes, while measles is not itchy. Scarlet fever, because of the streptococcal infection in the throat, you find a skin rash which is just like a sandpaper. You see the patient's tongue, you find strawberry tongue. You open the patient's mouth and look at the tonsil, you may find whitish exudate. There is pharyngotonsillitis with exudate. When you examine the hands and feet, you find a lot of scaling. So these features frequently differentiated from measles. And of course, you know that a patient having scarlet fever should be treated with immediate antibiotic like penicillin because it is streptococcal induced. Typhus fever, through the rickettsia infection, frequently these children get a rash on the central part of the body, maculopapular, and they got a very high-grade fever and severe headache and an exposure to the typhus germs. Some children have got a viral infection like enteroviruses, Coxsackie viruses, adenoviruses, and like a hand, foot, and mouth disease. And they got pustules, vesical pustule on the hands and feet and on the tongue. So these differentiate it from measles. I have given you a number of differential diagnoses for all these common infections in children. So we should not label each case of child having fever and rash as measles, but we should try to differentiate with so many clinical features that I have just mentioned in each case. Now, coming to the importance of measles as a community problem. Why do we give so much stress on measles? Let me tell you why. First, measles is the topmost killer, most important, most frequent killer of children among so many diseases which are vaccine preventable, like tetanus, like diphtheria, like tuberculosis, so like H influenza infection. So remember that regarding the mortality, measles is at the top of the list. Number two, the worldwide, it has been estimated that 20 million cases of measles are recorded every year throughout the world, a big number. And there has been estimated 90,000 deaths worldwide in just 1 year in the period mentioned. So this is a huge mortality. In Pakistan, it is estimated that although we are offering 2 doses of measles vaccine to our children through EPA program, but estimated that 2 million Pakistani children do not get measles vaccine every year. They are missed cases of measles vaccine. And number 2, people do not get second dose of measles. 54% children in Pakistan are not brought to the EPA center for second dose of measles. They just get 1 dose. Because with 1 dose, the level of immunity is just 50%. With the 2 doses, yes, it still can become significant, around 85%. And remember that measles can be very effectively, positively prevented by measles vaccine. So measles vaccine is the answer to measles cases. Well, WHO says that measles is a global disease. So we must try to overcome and prevent our population. The measles vaccine was invented in 1963. I said that just 1 strain, 1 virus, 1 vaccine. It's not like polio, which has got 3 strains and we have to use a polyvalent vaccine. Measles vaccine is just 1 single vaccine since 1963, live attenuated vaccine, and it was given in 1 doses till it was shown very effectively in different trials that one dose does not give long-lasting immunity. So 2006, WHO and UNICEF are advocating we must have a 2-dose schedule in the EPA program of all countries. And the WHO has fixed regarding the targets of measles eradication, that is, we must cover 95% children to get 2 doses of vaccine, so we can reduce these cases to less than 5 per million population with 95% reduction in mortality. And this has been the slogan of WHO to eradicate measles in the period between 2015 to 2020. Now, I showed you a case history. I hope you remember that. Again, coming back to the same picture, same child with a case history, our first clinical impression, maybe whatever you have written it, but please give me the correct answer. This is a case of German measles. It is not measles. Why? Because the rash cleared in 3 days' time. Number 2, the patient was immunized. And number 3, the doctor was very sharp. He immediately examined for the presence of suboccipital lymph nodes in the area, which are very clearly shown. So, on clinical grounds, this is a case of German measles or rubella. Other possibility I have already mentioned so far, and appropriate treatment I have already mentioned that. That is, there is no specific treatment for this disease entity. Give them supportive treatment like fever, like give them comfortable, like give them hot liquid drinks, and it will settle down in due course of time within 2-3 days time. So that is the answer to the case history that I just mentioned at the beginning of my lecture. Thank you very much for your very patient listening. Thank you.